So this is on. All right. Well, welcome everybody to the Golden Year Guide. So my name is Jane Bateman from Home Instead, and we did not call each other beforehand and color coordinate, I assure you. But that's the way it just ended up being. So I did a presentation for the Chesapeake Forum last year for the Alzheimer's Association. Was anybody here for that? Okay. So there were some questions that came up about, who to call when, who pays for what when it comes to senior care. And I thought it might just be a good opportunity to come back with the actual experts from each one of those entities to kind of answer questions for you, because so many times we hit that crisis and, we're emotionally, everything is heightened. Your loved one may have fallen and gotten hurt, and then you're having to kind of navigate through the system without knowing where to go and who to ask questions. So I'll just start by just introducing myself, telling you a little bit about who I work for and what I do. And then I'll let everybody introduce, and then maybe we might just start with one quick scenario, and then, this is going to be kind of a low-key, laid-back kind of a situation. We'll let you guys ask questions, and we'd be happy to answer all of them for you, okay? So again, I'm with Home Instead, and what we do is we provide the non-medical in-home care for seniors. So we hire care professionals to come in and help with things like meal preparation, housekeeping, transportation, all the way to hands-on bathing, dressing, toileting, transferring, and feeding. So we'll come in from 8 hours a week to help with meal preparation and take you to doctor's appointments, all the way to if somebody were to be bedbound, we can roll and change somebody in a bed. We are a private pay company, but we do take long-term care insurance, and we can talk a little bit more about long-term care insurance as well. So I'll pass it now over to Ginny and let her introduce herself too.
So my name is Ginny Blackiston. I am the palliative care coordinator at Talbot Palliative Care, which is under the umbrella of Talbot Hospice. So I can talk a little bit about palliative care and hospice and what that might look like as we move forward. With our palliative care program, we offer home-based palliative care to help with symptom management, goals of care discussions, advanced care planning, coordination of care with your providers, and then if needed, when the time comes, we can help transition patients in the community over to hospice services. So that's kind of what we do in a nutshell.
Good morning. I'm Samantha Butler. I'm with Home Call Home Health. And so we provide skilled nursing care in your home, physical therapy, and occupational therapy in your home. Medicare covers our services at no cost to you, and usually other insurances, it just depends, but usually there's no copay with that. So that's something a lot of people don't know. But we will come to wherever you call home and provide the services either once a week or up to 3 times a week. So the differentiator between home care and home health is, Jane and her team can go out for those longer hours and help with those kind of everyday needs, and we can come out and help with like the skilled need. Whether you're coming out of the hospital or out of a rehab or just need a little TLC, we're here to provide that for you as well. So we love what we do. We love keeping, everybody in their home, or again, wherever they call home. That's us kind of in a nutshell. So I'm happy to answer any questions. All my handouts are there. We have a lot of specific programs for a lot of different disease management too. That's it.
Follow all that. I'm Erin Sharp. I'm with PAM. It stands for Post-Acute Medical Rehab. We are a short-term acute rehab. I'm over in Delaware. I have 3 locations, Dover, Milford, and Georgetown. And you're going to say, why do I need to know about Delaware? Like, that's so far away. It's about an hour away, which isn't bad. But if you need a short-term acute rehab, you're gonna wanna come to us. We are all private room facility, which is kind of nice. I don't know about you, but when I'm sick and I don't feel well or something's happened to me, I don't even want to share a room with my husband. So I like having the privacy of not having to share a room with anybody, not having to share a bathroom with somebody I don't know. So you really have that kind of convenience to get some good care. Also, all of our care for our physical therapy, speech therapy, occupational therapy, or respiratory therapy is all one-on-one care. So at some locations, at some rehabs, you're all gonna sit in a circle just like this, and you're all gonna do the same 10 exercises, and then we're gonna take a break. And we're gonna do the same 10 exercises, and then we're gonna take a break. At my facility, I'm gonna treat each one of you individually. So maybe some of you have a dog you need to walk when you get back home. Maybe some of you have steps that you need to get back up. Maybe some of you have a big bed you need to be able to climb in and out of. We're really gonna focus on you and your care to get you that personal attention to get you back home. I do have my information on the table as well. I know, like I said, that an hour seems far away, but an hour to get some great care. We are not a long-term care facility. We are just an acute rehab. So you're with us for about 7 to 10 days. It's intensive therapy, 3 hours a day, 5 days a week. Again, that sounds like, wow, how am I going to do 3 hours of therapy? I felt the same way. I'm a woman of a certain age. And I thought 3 hours sounds like a lot, but it's little bite-sized pieces. So you get up in the morning, do some therapy, getting dressed, take a little break, take a nap at your own room, do what you want, watch TV. You do a little therapy before lunch or after lunch, take a break again, and then a little more therapy in the afternoon. It keeps you moving, keeps that therapy going to really get you stronger, like I said, to go better, to go home. There's a couple different ways that you can access our services. We can take a referral from home from any of these ladies. Or we can get a referral from the hospital. If you have any questions about that, that can be a little confusing. I'm happy to talk to you during this talk or afterwards. But if anyone needs acute rehab or needs rehab in general, please think of us and I can help you answer any questions.
Hello, I'm Megan Pinder. I'm from Hartfield Assisted Living here in Easton. We provide assisted living and memory community. Hartfield is part of 5-Star Senior Living. We've been here in Easton for 24 years now. You've probably seen us on the bypass. The cow is not ours, that's one in there. I get that question a lot. Yes, so we do have assisted living and memory community. We have lots of activities, 7 days a week exercises and 7 days a week happy hour. So that's all very important to us to keep independence and socialization. And we are pet friendly, which is a big deal for me. I don't know for everybody else, but I'm happy to answer any other questions and my cards are on the table as well.
So I thought we could just start with a scenario and kind of let you guys feel what or experience what those steps might be when something were to happen. We all know each other. This is a small community. We all are, referring to one another when we see a need for somebody in the home or maybe in the hospital. I'm going to call Samantha or Ginny or Megan and Erin and just let them know, hey, here's the situation. And we all know kind of how to get those referrals and such. So let's just say that you're at home and you're by yourself and you fall and you break a hip. And then you're probably going to go to the hospital, have some surgery, and they are going to want to get you out of there as quickly as possible. So from there, you're going to go to Erin. And you'll spend some time at that facility. And Erin, can you just talk a little bit, I guess, about how that process works as far as, how that's paid for and the referral and stuff like that? Like, who gives you that information?
So when you get to the hospital, you're obviously going to see the ER, the surgeon, they're going to set you up for surgery. So now we're talking like maybe the day after surgery or maybe the day of surgery. They're going to come to you and they're going to say, you need rehab, here's some options. What they're not going to tell you though is some of the options, not all the options are the same. So there's acute rehab and then there's long-term rehab. So long-term rehab is what people would normally call, I hate to say these words, but the nursing home. That's like a skilled nursing facility, and I'm an acute care facility. So again, we're about 7 to 10 days. We're gonna get you that wonderful rehab, and we're gonna get you back home. The difference between myself and that skilled facility, the skilled facility does about 15 minutes to half an hour of therapy once a day. You might get that 4 days a week if you're lucky. The rest of the time, you're gonna be kind of at the mercy of whatever else is going on. They're obviously gonna give you food and drink and all that stuff. But the therapy is gonna be smaller increments. So we do pride ourselves, like I said, on that intensive therapy. So you're gonna come to us, the case manager's gonna say, where do you wanna go? If you can come to Pam, that's your first choice. And then they're gonna ask you your insurance. Medicare covers everything for us. If you have an Advantage plan, we need an authorization. That can get a little tricky, but we do navigate that process with you. So we'll come in and say, we just need a day or two to get that authorization. If for some reason we need to appeal a couple things, then we'll do that process for you as well. We'll get you to PAM rehab. There's a couple different ways. The hospital will either bring you to PAM, or we do have a van that can bring you to PAM as well once you're accepted into our program. And then you would come to us for therapy. While you're in our services, we're going to start talking to you about next steps. What does it look like at your house? Do you live by yourself? Do you have steps you need to get up? Do you need a shower chair? Do you need these kinds of things? Are you planning on maybe moving from your house to an assisted living? And then we would start calling all of our friends here to see what you need. So the next possible thing I would say is probably Samantha. They would do home services, so I'll pass it to Samantha.
So once you get discharged from rehab, we're already set up, the rehab will reach out to us, send us a referral, and again, whatever skills are needed. So whether you just need PT or physical therapy and occupational therapy, or if you need some medication management too, we'll send a nurse out. So think of it as we're kind of, slowly getting you back, no pun intended, but back on your feet and back at home into your daily routine. So that's where we kind of come in and just assist you in that, coming in and helping with the, keeping you moving, keeping you up with those exercises so you don't end back up in the hospital. Or again, if that medication management's needed, just to get you back as independent as you can be in your home. And so our nurse will come out, do a full assessment, and you'll see in my brochures, we do have those specific programs, and you don't even have to ask about that. The nurse is already doing that checklist to see if you would kind of qualify for a more specific program. So she comes out, does her assessment, whether it be the nurse or the physical therapist. They're both doing their checklist. And then from there, we contact usually your primary care physician to follow with you during the care to sign off on any orders that may be needed. And we update your primary care physician as we go along. Usually myself will do that, or the clinician will call and talk to their assistant, and just keep everybody in the loop. That's a huge thing, is to be as communicative as we can be with all of your care providers. Whether it be also Jane coming on board, we keep in contact with everybody frequently. And then sometimes you're with us for a couple weeks, and then, at that time our nurse will say, hey, listen, I don't think you need us anymore, or you don't need me, we'll keep up with physical therapy. So, you can do one of the two. You don't have to have, the 3 disciplines, ongoing. And then at that point, you're good to go. And sometimes we still check in with you after the fact just to say, hey, is everything still, you're still feeling good, feeling confident, and all those things. If you say, hey, actually, no, not really, I really feel like I've lapsed a little bit, then all we do is call your primary care physician, get a new order, and we can come in and out. So whatever the case may be, we can always start back up with you too. And yeah, I think that sums it up. Yeah.
And you can also go into the assisted living.
Yes, yeah,
right?
you can definitely go into assisted livings, and in your homes.
Yeah, and sometimes it doesn't always require a break. If we're in the home and we know that, if we're only there, say 12 hours a week, but we know that you had a fall when we weren't there, we will also reach out to Samantha and say, hey, she's can you come in and pinpoint some weaknesses and start some physical therapy? So it doesn't have to require this whole process. You know, Samantha's, home call can come in, so, and, like you were just saying, she can be recertified, right?
Yeah.
They can be recertified, so it doesn't have to just be the 6 weeks or whatnot,
And
so.
it doesn't have to be a big catastrophic event that, that happens. It could be if you go into your primary care physician and just saying, hey, I fell, last week and I'm a little weak, my balance is off, might be something going on with your ears. It could be a whole range of things. And then your primary care physician can just, shoot me a call and send me an order and we can go from there. So it's as simple as that, for sure.
Can I ask, as each person is talking, they'll mention, instead of just over there, but mention what organization, what company you're in, so that we can keep track of who was who,
Yes,
with
yes,
what.
yes, for sure.
Yeah, definitely.
Yes, yep.
And so Samantha, you're with,
With Home Call, and we're the home health company. So, physical therapy and nursing care in your home, or, in an assisted
so
living.
you're not basically rehab, you're all types of things.
Yep, in your home. Yep, it's appropriate, of course.
Thank you.
Oh,
What's
yes.
the difference with assisted living, she calls herself, between these two?
Just repeat the question too.
Okay, so what's the difference between us and assisted living?
Yeah.
So assisted living is where you could come to live after you're using this, and so,
Oh, that's not your own home, this is in another facility.
yes, we have our own community, our own building, so you would have an apartment in our assisted living, and all these resources could actually come into your apartment, you're at home at the assisted living.
You don't offer any of the services. It all needs to be brought into Hartfield's.
Well, we offer different services. We don't have, we do have a OT and PT in the building, but we also utilize the services of other agencies. So we have 24/7 on-call nursing, caregivers, medication management, restaurant-style dining activities and things like that, but we do also utilize everybody else's services if they need more than what we have in the community.
And if there's no support at home and somebody were to need a lot more care, they might go straight from Erin's acute rehab facility in Dover straight to Megan at assisted living instead of going home with physical therapy and home care. Yes.
I understand that assisted living has wait lists. So how would that impact if you had,
Okay.
if you were critical and you needed to go there, is there a wait list or do those people jump above other people or?
So, yeah, I'm Megan from Hartfield's Assisted Living. So right now, our memory community does have a wait list. Our assisted living community does not. That's why I think it's really important to learn about things before you get into crisis mode. This is a scenario, luckily right now, we'd be able to help you. And we even offer respite services. So if this happens and you weren't really ready to move in forever to Hartfield's, you could come stay for 30 or 60 days. You are gonna sometimes have the chance of having a wait list, depending on what size you need.
Could you just give me an idea of generally how long it would take to get into assisted living if you didn't have a reason that you had to go right away? Like someone like me who's aging, I'm in my mid-70s, what should I be considering?
I would just start looking and researching now of what feels like home to you. And then you'll know all the processes of what you need to have ready so it's not an emergency. And that way you can live your life in assisted living, your quality of life, and you're not just coming during an emergency. You can be independent there.
So you're implying that the usual situation is once you're in assisted living, you're there forever?
Not always.
I mean, you talked about.
There is a respite program,
Yeah,
yes.
the respite, but I mean, other than the respite, the usual situation is you're there.
You're there to live. in your apartment, make it your home.
Okay.
Do you have just apartments or do you have cottages?
We just have 3 different styles of apartments.
Okay. So people with dogs, is there any fenced yard?
Yes, we have 2 enclosed courtyards. We just had a corgi move in yesterday named Toffee. So we have 2 dogs living there right now and a cat. We had a welcome sign for Toffee, but it's 2 enclosed courtyards, so you can let them off the leash in the courtyard, and let them run around. And they'll have plenty of friends, because everybody wants to see the animals.
Yes. Do you ever have an open house?
Yeah, so we have lots of events, like Saturday, for instance, I'm having a pie baking contest, and we'll have live music, food, drinks, and you can come to those type of events, and then I can give you a tour while you're there. You can meet some of our residents that live there now and ask them questions, which I really recommend, meeting the families and the residents to get their opinions on life at Hartfields. I can give you my card when I leave.
Now, you all self-pay?
We are private pay and long-term care insurance.
So Medicare, Medicaid, you don't even consider it.
No, ma'am, no problem.
Medicare will only pay for medical care. So
Okay.
assisted living is,
Oh,
so, but Medicare will pay for the PAM rehab and then also the in-home rehab as well, and palliative, yeah. So just to give you a kind of an example that encompasses all of us, is just recently we had somebody who did fall, break a hip, went to rehab, so would have gone to someplace like Aaron's, came home and is using in-home physical therapy and occupational therapy and nursing actually, so that would be Samantha's organization. This little lady does need 24-hour care. It is expensive when you look at one-on-one care with an organization like Home Instead. If that gets to be a little bit too much for the family, or if her needs just are just a little bit too much, we would then refer her over to Megan and say, hey, Megan, you know, we have somebody who needs 24-hour care. She would not get one-on-one care, but she does have somebody there all the time, 24 hours a day, meals, transportation, medication management, everything. So at home and in assisted living, Jenny can come in and help with palliative care. So again, just another resource. So Jenny, would you just talk a little bit about palliative?
Would you define the word?
Yes, so palliative care by definition is medical care for persons who have a serious illness. We can help with symptom management. So an example could be someone who has lung cancer, who is actively seeking treatment, but may need help with symptom management at home. Nausea, vomiting, things that are a side effect of that treatment. We have a nurse practitioner who can come to the home and help you with those symptoms, help manage those symptoms. Also, advanced care planning. So moving forward, what does this look like? What does this illness look like? Are your goals outlined? Does your family know what your goals are and what your wishes are for treatment? And are those in place? And that's something that we can help either get in place, review during each visit to make sure that it's still what your wishes are. We also have patients in the community who they may be diagnosed with dementia. There's a caregiver in place, a loved one, spouse, child who is caring for them. There's a lot of caregiver stress and burden, a lot of education, a lot of additional community resources that we could be pulling together to help that family be able to provide the best quality of life for that loved one. Behavior management, questions about appetite, things that are related to the illness. Any of those symptoms, our nurse practitioner can come to the home and help with. there may be a point where our nurse practitioner has the discussion that if we're not continuing to seek treatment, that then hospice may be, the time to transition to hospice. So she'll talk to you about what that looks like. But we do have patients that stay with us on palliative care through their journey and don't transition to hospice. So we're there to offer support for the patient and the family.
Stay with us, you said. In their home?
So we can see patients wherever they call home. So whether it be their private home, assisted living, skilled nursing facilities. The hospital also has a inpatient palliative care program there that they see patients in the hospital. So if a patient that we're following under palliative care transitions to the hospital, then they are seen by the palliative care team, and then we can resume care once the patient comes home.
Okay, are you a standalone company?
So we are under the Talbot Hospice umbrella.
You're under hospice umbrella. So people can go from your services to hospice and even from hospice back to you, depending on what is going on.
Yes, so if a patient no longer needs hospice services, which it does happen, we do have patients that graduate, patients that also revoke hospice if they want to continue to seek treatment, then we can follow them with palliative care services at home. What that looks like is we're able to pull the social worker, chaplain, volunteer services from hospice. With palliative care, we utilize those services as well. And then you have the nurse practitioner who's going to be follow up and working with your providers.
So do people contact you directly, or do they contact hospice and then get connected to you?
No, we have a direct line into palliative care, so you can call us. We can actually talk to you about what the services would look like. We can send a referral request to your providers, or you could talk to your primary care provider or specialist, and they could also send us a referral.
And how again is the cost taken care of? Is there anything other than private pay?
So we practice just like you would see a provider in the office. So Medicare Part B pays 80% of the nurse practitioner's visit. And then if you have a secondary insurance, they would pay the 20%, like your copay or deductible. The only difference with that is if there's a Medicare Advantage plan or a commercial insurance, we would want to make sure that we get prior authorization first to make sure that you're not going to have any out-of-pocket expenses. So we try to do that first before we even schedule the nurse practitioner to come out.
So, question just left.
It's a lot of information.
Say most people, I think, have Medicare and then they have a Medigap policy, a supplemental. Do they pay anything?
Not usually. There is at the beginning of every year, which for Medicare, that you have your deductible that you have to meet. So sometimes,
That's Part B.
so that's the Part B deductible. So sometimes there may be a little bit that your secondary or your gap coverage doesn't cover, but for the rest of the year, we don't find that patients who have Medicare Part B and a secondary insurance have to pay any copays or deductibles. It's just as if you're seeing your provider in the office. We bill the same way.
Okay, so is there a time limit as to, they say that hospice is, if you doctor says 6 months, you qualify for hospice. Is there a time limit on palliative care?
So we do not have an official time limit, no. Our practices, even with hospice, the sooner the better. So the more information you have about our services early on, the better care we can help you, better care and quality of life you can have. So with palliative care, we do not have a, if you've been on palliative care for 2 years, we're not gonna discharge you. We'll keep you on. We've actually had some palliative care patients that have been with us since the beginning of our program, and that was 2019.
Okay, so this is fairly new.
So this is fairly new for us, yes. And we follow along. We are there to offer support. We see patients at home that sometimes may not be able to get out to their providers. So we're an extra set of eyes and ears, that extra layer of support going in, communicating to their primary care or their specialists, letting them know what we see. Sometimes we see the bigger picture when we're at home, in a home setting than what might be explained to a provider in your 15-minute appointment in the office. So we're looking at the big picture when we go in.
Okay, and what's the name, what is it called? I mean,
So we are,
palliative care, are you're a company, or you said something about being under
sure, so we're Talbot Palliative Care,
Talbot County Palliative,
just Talbot Palliative Care.
just Talbot Palliative Care, and you started in 2019. Okay, now, does palliative care, you said you have a nurse practitioner and all. Do you have individuals who come to the house and maybe, help with a bath or anything like that?
So we do not with palliative care services. When a patient transitions to hospice services, they do have caregivers that could come out and help with that, but with palliative care, we do not.
And the hospital has a palliative care, someone mentioned, and I think I've seen in the paper about the hospital has a floor for palliative care. Are you connected? Do they still have this? I don't know.
Sure. So back to your last question about caregivers at home. We as palliative care do not have them, but that's where we would bring in Jane if we needed to refer to Megan, those types of things. Those community resources, we help families and patients find, whether it be rehab, home health. We do refer to home health services as well. And we do have some of our patients that go out of state to PAM for rehab. So we kind of loop in all of the ladies you see here to kind of help with that.
So you sort of help organize
So
all
we can
of
help.
that.
Mm-hmm. So the program that is at the hospital, we are not a part of them. We're separate organizations, but we do work with them. So when we have patients who we feel might be better served by a clinic, in a clinic setting, then we can refer to the University of Maryland Palliative Care system and vice versa. When they have patients that they've been following in the clinic setting or in an inpatient setting that are unable to get out of their home or might be better served by a home-based program, then they refer to us. So we do communicate with them pretty often, especially when one of our patients is, in the hospital for an ER visit or an admission. We try to communicate with them to kind of let them know what we've been seeing at home, so that they can help carry on that care while they're there in the hospital.
So when a person, the big thing is do your wishes and drop it in the box outside of the hospital. Now, is this something that is shared or say, I would have to share my wishes with you since I dropped, we have this thing, a program somewhere, and we all filled them out, took them to the hospital and dropped them in the outside box. So we would sit down and discuss and go over all of this, that, and the other with you so that you, the palliative care person, would know our wishes and all of this. But that would also be shared because you said you're sort of under hospice, right?
So when we do an advanced care planning with our patients, we review their goals of care. So if you have a MOST form, which is very important to have,
Yeah, you don't hear much about the MOS form anymore. I mean, they had this other form and it was totally not the MOS form. And I asked someone, and you don't hear about it like you did there for a while. All you heard about was the MOS form. You had to fill it out and all this.
So we encourage you to do a MOLST form. We can help with that. We can answer questions about what that might look like. You can review that with the nurse practitioner. I think what you're referring to is advanced directives.
Yes.
So the advanced directives that you dropped in the box are then uploaded into a system, and most providers that are in the University of Maryland system can see them. However, providers like Jane and Call, did you see? So, sometimes they can see those advanced directives, but sometimes they can't. So it is very important for you, if you're seeing a provider, especially if you see a University of Maryland primary care provider, but maybe your cardiologist is Luminous or MedStar, they can't always see that information. So we want to make sure that we're trying to share that with all of your providers. So when we do a MOLST form, we send that to everyone so that they have a copy. If it's reviewed and updated, then we send them a new copy. But the idea is to make sure that you have your wishes available to your providers. We do also send it to the hospital when we do a new MOLST form. In case there is an emergency situation, you have to call 911 in the middle of the night. They have a copy, you'll have a copy at home, and your providers will all have a copy.
You brought up something that I wouldn't have thought to bring up, is that there is a form, which I have not filled out, telling whether you wanted, is that on the MOLST form, whether you want CPR? Is that part of the MOLST form? Or,
Yes.
or is there a separate one?
So the MOLST form reviews, if you would like CPR, if you would like to be transferred to the hospital, blood transfusion, IV fluids, tube feedings, all of those things are covered on the MOLST form. And there are several options that you can choose from on that MOLST form. So it's really good to have that discussion with a provider and your family about what your wishes are.
Could you explain what you're talking about?
Yes. So a MOLST form is the, and I'll probably say this, Maryland.
Medical order of life-sustaining treatment.
Oh my God.
So MOLST, MOLST. And I will say that, at home instead, when I go in and meet with a family, that's one of the things that we do provide, because we will do CPR unless you have that filled out and on your refrigerator saying otherwise. So all medical personnel must follow that form, and it does follow you.
Is that a state form?
Yes.
It's a state of Maryland?
Yes.
I moved from New Jersey.
And where did they come from?
Well, you can download it off of the internet, but you have to have it signed by your physician.
I can send copies out. I've got all of you on email. That'd be great. And we've got it saved from a class last year, so I can send you that.
Don't trust me in the computer.
Yeah. It's not my Hartfield, I'll print one out for you.
Now, I know a person whose wife was given CPR, even though, and she was under hospice, even though but he couldn't find the form.
Yeah.
Type of thing. And somewhere through the years, I heard something about a yellow band since I've lived in this area. Does anyone know that there was something, and if you had it on, that it indicated no CPR?
Actually, years ago, before the MOLST form, when you filled out the form with regards to no CPR or yes CPR, as part of the form, you cut off the bottom of it and you wore it as a band. So they eliminated that with the MOLST form. But my experience is if you have the MOLST form, it's no good in your desk or your dresser or by your bed. You have to carry it in your pocketbook. And hospitals, University of Maryland Hospital in Easton, doesn't always follow it. My girlfriend's husband was sent from a dementia unit to the hospital because they couldn't handle him. And she had all the forms right in front of her, and they still wanted to do everything under the sun, and told her that if she wasn't doing it, she had to send her back to the unit. She had to get a friend that worked in the hospital, a nurse, to help her enforce the MOLS form. He went to some of the floor in the hospital, and he died 6 hours later. So the MOLS form, the bottom line is you can have all this paper filled out, but you need to have a living advocate to make sure that everything is carried out.
Right, but if you're out in public or anywhere,
You have to hope that they open your pocketbook, or if you're in your car, they look in the glove compartment
yeah,
of
if
the
you're
car.
at home, you can have something on, you can.
Your refrigerator.
Door, or your refrigerator.
There's no guarantee they're gonna look for it, believe me.
See, this is what I was saying, that I knew a friend that they did CPR on his wife, and they, he panicked and couldn't find the form, at that time, and, type of thing. So that's why I was asking about the yellow band. If there was something, then don't we need something like that? Because if we do our advanced directives and we drop them in the box, but seems like the most form is almost more important.
It is. And
Than our advanced directives, but there's no way for the ER to know or anything. I mean, I've given everybody, all my doctors, my advanced directives, but even if you give everybody your signed most thing, then they have to go to the computer somewhere to find out, oh, they have a most and they say no CPR. Well, that's just not gonna happen. So as a community of people, and hospice and all of this, do we not need someone to figure out how people can have a wristband that says no CPR? Is that not something we need the community to come together and figure out?
I think there's no great answer for that. I think that no matter what the industry is, there's no perfect industry, right? Like,
This is really bad.
yeah, I don't know the answer to that. That's above my pay grade. So, but as far as that, the MOLST and them doing CPR, does it happen? Yes, I'm sure it does. Yes. But I think we all are doing the best that we can, as far as the industry goes, the healthcare industry. It's just not perfect. There's no perfect answer. But Megan, go ahead, say what you were saying.
I was just gonna say, when you move into assisted living, or even if you're there short-term for respite, or you're staying forever, in order to, before you can actually move in, we have to have a MOLST on file. And all of our nurses, care managers, the dietary aides, everybody is trained on everybody's MOLST. And we keep copies of it right at the front desk. And if you go out, we hand it to the EMT. We keep copies of it in our bus. So if you're going out to eat or going to the theater with us, we all have copies of that as well. And for you, I'm sure your doctors, if you can't print it out, or, if you forget it at home, if you ask your physician next time you're at the doctor's, I'm sure they have copies of it there.
And if you download it from the internet, there's a very good sheet that gives you a better explanation of what all the choices are. So, I wouldn't recommend just going to the doctor and say, help me fill this out. I think you need to read the backup information, because it's very well written. It's in language that the common individual, not a medical person. So read it and think about it. And you can always change it. You can change it every month if your life changes.
And if you can't print, you can always take it, if you have.
Not quite as incompetent is that?
I have a printer, but we can't get it in my iPad.
How do you get it off the internet?
Library
What internet do you go to?
and print.
If you just Google MOLST,
But I think,
All
I
capital
think she said
letters.
you were gonna send it.
I'm
She's
gonna-
gonna send it.
I'm sending it to you.
Oh, okay.
I'll send you
Thank
one.
you.
You won't have to search for it.
Regarding, the palliative care that they have at the hospital, is that something that it only goes for 90 days of coverage with Medicare, and then they would change to being home and under possibly you?
not that I'm aware of. So the palliative care at the hospital sees patients when they're an inpatient. They also have an outpatient clinic at the Cadmus buildings. That's a University of Maryland palliative care outpatient clinic that you can see their providers there if you wanted to go into the clinic. We offer home-based visits and telehealth visits if needed for check-ins, but we really try to do that home visit. We just feel like that gives us a better picture. It gives you more opportunity to kind of have that one-on-one with the nurse practitioner.
Okay, so if someone were under your care and then they were hospitalized or whatever, do they then transfer to the hospice, or do you follow up at the hospital? How does that work?
So we do not have privileges with palliative care at the hospital, so they would be seen by the inpatient palliative care providers there, and then we would resume care once you're discharged. But we do work with them, we do communicate with them there at the hospital.
Is the palliative care, your situation, is it limited by, the same as hospice, the 6 months, or is that not part of palliative care?
No, there's no limit on the time for palliative care.
I have a question for Megan. Does your program have independent living as well?
We do not have independent, we're just assisted in memory.
Well, I guess I do have another question. You talked about starting in 2019. So is this unique to have kind of this coordinated approach that you all have, or is this something that you would expect to find in other communities?
Well, we just kind of came up with the idea to put this together because we knew that there was a need for it. And I think there's a lot of need for it in the community because people don't know, kind of where you go from here and who pays for what. So we just happen to really know each other. But there are other agencies, there are other rehabs, there are other in-home, care agencies or home health and assisted livings and such, but, yeah.
So it's not a national model. I mean, you just kind of
Oh,
pulled
no.
it together.
Yeah, no, we could go on the road though.
Do it.
Anybody have an RC?
We start in Hawaii and work our way back.
That's right, not Florida.
To answer your question, the health department puts on programs of health fairs, they call it. So does the senior booklet center. So if you watch the newspaper, there'll be at least one each spring and one fall, where all the health agencies servicing any health need, palliative care, assisted living, what they call total care communities now, like Bailey Chase, that are all represented. And it's usually, a morning session, maybe with lunch. So
It's May 21st this year.
yeah, the information is out there. Okay, you just have to watch when they have a program.
Yeah, that's at the fire hall, right?
Yeah, May 21st this year, we're starting advertising.
May 21st, yeah.
Okay. 21st.
Of what?
Yeah, they have one.
Of May.
You're there.
Megan here.
What do you put? I'm writing it right now. My 2005 calendar.
Well, no, we had one in May, but you're not going to have it in May.
Oh, I thought you
This
said.
is,
It's going to be in May?
Yeah, I just came from the meeting. It's going to be May 21st at the fire hall. But then we'll start advertising soon,
Health fair.
the health fair. So it'll be
They have.
kind of like this, but personalized. You walk up to the booth, so we'll all be there. Yeah.
I just kind of wanted to add in general, because I do get these a lot. I have another crew in Delaware that I use, and then we're happy to be here with our partners here. But what I hear the most, and I see, because I also go to the hospitals and I'm transitioning people from the hospital to all these resources. So I not only represent Pam, but if I feel like Pam isn't a good fit, I'm happy to, say, hey, well, I know somebody else that can help you because you seem to need this option. I think the biggest thing, and I'm going to speak for everybody, is that you need to know your options and you need to be your own advocate. So I know sometimes it isn't perfect to have this piece of paper on hand or that piece of paper on hand, but tell somebody else, tell a neighbor or friend, a family member also your wishes, but also be your own advocate. So let's say you do end up in the hospital or you are at the doctor's office. Ask for what you want. If have one of those Medicare Advantage plans and they're denying you, ask for an appeal. Like, you're allowed to ask questions and you're allowed to ask for the care that you want and the goals that you want to have. So whatever, like, let's just say you go to the hospital and they say, you need to do X, Y, and Z. If that doesn't seem like that's a goal for you, ask a question and see if you can get a different option. If you're at the doctor and you don't feel like your needs are being met and he hasn't addressed your medications, make sure they're addressing your medications with the doctor. If you feel like you want an assisted living, go look at options. If you feel like you want to talk about palliative care, like, just be your own advocate. What we're seeing a lot in healthcare is that people get into, like Jane was saying, in a crisis situation, and then someone else ends up guiding your path for you because you don't know your options. So they'll just come to you in the hospital and say, here's a piece of paper, you got to leave tomorrow, pick something. And you don't even know what you're looking at.
They will do that. They will do that, and they will give you 14 to choose from.
Correct. So it's good that you're coming to these resources. Go to the health fairs, start talking to your family, start asking around for different information, because what you don't know, you don't know. And maybe there's a different option. I make my mom come to Aldi's in Delaware. I plant her in the audience and actually give her questions to ask. And say, hey, ask about an Advantage plan. Ask if you can get out of it. Ask about long-term care and talking to your kids. Because I've had this is great information for me too to take back to my parents. So ask all the questions and get all the information, because again, we're not kidding when we say this is not a joke. You will end up somewhere and someone will hand you a piece of paper and say, make a decision right now. So make sure you're getting all this information and keep asking all these questions, because you got to be your own advocate.
From the moment you're admitted to the hospital, they are looking to discharge you as quickly as possible. So, yeah, you're on the clock. Yes.
Now, I was in the ER and my daughter's 2 hours away and, it was middle of the night. And they had a service that they called that would take me home from the hospital. And so somebody asked on Facebook about this, and I put that information in, and they wrote back and said, no, the hospital didn't have anything like that. Does anyone know that they still have that? I mean,
that was the taxi service, most likely.
It was an individual person.
Okay.
TDK or KDK or something like that. And it was perfect. I mean, and
did they see you inside? Did they take you inside and make sure you were safe, or did they drop you at your door?
No, they took me in the house, and I also used that company when I had oral surgery, and I was still totally out of it when I had the oral surgery, so I couldn't tell you anything about the woman who drove me home, about the vehicle or anything. But I do remember her helping me take my coat off and get settled down and this type of thing. But I was feeling.
Was it a car? Was it a car or was it like a van?
No, it was cars. So both times it was cars, and it was a blessing. And there's so many of us, that do not have family here or do not have close friends that are able to do these because they're all old like we are. And I thought that was really sad that the hospital did not have that anymore.
Mm-hmm.
And
The hospital, the medical community in general is not what it used to be. So
transportation and coverage and things are not the same. It is quite different. I was actually in the hospital yesterday, and I just said Medicare, the medical system and what they cover and what they'll do for you now is much different. I actually met a woman yesterday that was getting, had a knee replacement and then she needed a revision. And because she had just had the surgery, it was kind of a mess with her insurance. But she was confused as to where she would go and what she could do, because in the past, if you had certain surgeries, you were in the hospital for like a week. I don't know when you all had your babies, but I was in and out in a day. My mom was there for a week hanging out and she had me. So the care is a lot different than it used to be. The services are not the same. The coverage is different. Yeah.
That I would, it had to go to the emergency room, so it was very recent, it's not like it was, but it was last February, I think.
And it might have even changed since then.
And somebody, they said, no, we have somebody that could take you home, and I said, what about the cost? And they said, we have an arrangement with them. I mean.
That's wonderful then. Okay.
And so I felt really bad for this person that I gave the information to, that said that they said that they didn't have it.
They might not have it anymore. I know in some of the hospitals where I work, they do not have transportation unless you need an ambulance. Yes, ma'am.
Yeah, I'd like to hear something about long-term care insurance. Who applies for that? Who, is it time lapse sorted? Is it, are you reimbursed or is it direct payment for this? Somebody talk about long-term care insurance?
So I think Megan and I probably could for the most part. That's a whole nother presentation. But what I can tell you is that there are a lot of different policies out there by a lot of different companies. And I've heard that the best time to actually start purchasing and paying on a policy is between the ages of 55 and 60. Because if you wait until you're 80 or 85, most likely you're not going to be approved. Or it's going to be extraordinarily expensive. But long-term care will pay for in-home care, usually, assisted living, and then nursing care. There are some policies that will cover $100 a day. There are some that will cover $9,000 a month. I mean, you just don't know, because it depends on what you wanted to pay when you initially started that policy years ago. And most likely you will have been paying on it for many years before you can make use of it. Unfortunately, a lot of people wait too long.
But not only that, from my experience, I'll tell you that the insurance companies made a terrible mistake. Early on, they were much too liberal, and they've been trying to tighten up ever since, which means if you're paying out every year, the price goes up, and I mean 20%, 30%, 40%.
Yeah, and I don't think State Farm even sells the long-term care policies anymore, from what I understand, but.
They've chickened out.
Okay.
So there are agents associated with particular companies?
Yeah,
Be
so.
in touch with those agents and.
Yeah, so the policies that we work with a lot are Genworth, John Hancock is another one, MetLife, there's one called CNA, I believe. I think Nationwide even has some, and then some companies that you've worked for will have them through different policies. But a lot of times there's an elimination period where you have to pay privately for 30 to 90 days before they'll even start reimbursing. And how we do it at Home Instead is we bill you, you pay us, and then we send the policy the information about the tasks that we completed, because they want to see that you really need care. So you're going to need help with the ADLs, which is activities of daily living, which includes bathing, dressing, toileting, transferring, and feeding. So they want to see that at least 2 of those are covered.
Say it again?
Bathing, dressing, toileting, transferring, and feeding.
What do you mean by transferring?
So you might need a little help getting from your wheelchair to the bed, things like that, yeah. So, so what we do is we have to send, like I said, them the policy, the information about the tasks completed, because if we send them the information and they say, hey, you guys were only doing transportation and meals, we're not gonna reimburse this family. So that's what we tell everybody from the get-go. That's fine if you want to make use of this policy, but these are the things we have to be marking off. Because a lot of people say, I don't need help with bathing and dressing. So, but a nurse will always come out to the home as well to assess and make sure that you need the care. We had a gentleman that we started care with, I think it was like about 88 years old, put the claim in for the policy, and he ended up passing away within a month. So, you don't want to wait too long. So, Megan, can you add anything to that?
We basically do the same exact thing. So it's either the 30 to 60 days where you're privately paying, and then you pay us and you get reimbursed by your long-term care policy. So everything Jane said is the same way that we would do it in assisted living.
I just want to add, if you have one of those policies, let your children know. I've seen people be in different places and then the kids come in and do a clean out of the house, or they're going through paperwork, oh, mom, it's a long-term care policy. Well, it's been 5 years ago that she could have been using that policy. So make sure somebody else knows about those policies.
Does anybody have any other questions for us?
Well, okay, this is probably not appropriate, but since we have a little time. So I have a 96-year-old aunt who is not into the state, but she's resistant to everything. Any hints on how I can get her to start realizing, I mean, she's 96, she's living alone in Albany, New York. And her children are not, her children are not in the same state.
Yeah.
Any hints on how I can start to get her to look at this?
Right, yeah, I think everybody's different as far as how we would approach that. But I will say, this is gonna be engraved on my tombstone, everybody has the right to make a bad decision. So the crisis has to play itself out sometimes. And I would say that's generally when we get the phone calls, is after the crisis.
That's what we're kind of all waiting for.
Yeah. So, oftentimes we tell families, tell your mother or your aunt or whoever that it's not for them, it's for you. Because you are worrying and you want peace of mind knowing that she's cared for because you love her. That's oftentimes how we will approach it. Do you have any?
Because we get this a lot. So I think another thing too, and it depends on who the person is, but if you research some assisted livings and that's the route that you're thinking, talk to the sales director, see if you can go in for lunch. It doesn't have to be a tour or like one of the events, a party or something. So, because I think people get an idea in their head, they're like, no. And once they walk in the door and they see this beautiful place with all these people laughing and dancing and doing the Macarena on a Friday afternoon, it's going to be different. And it might not be, you might have to go to 5 different events, but getting people in and seeing it, I think really, really helps, because I think we all get ideas in our head and get scared. So I would call, if she stays around that area, or if you want to bring her to but going to events, going just to sit and eat at lunch or happy hour music, I think is a great resource.
Thank you, that's very good.
I think another,
I have a stepmother who's 99, and 2 years ago, and I was helping her maintain the house on the water in New Jersey, going up a month after my father died. And on her 97th birthday, she said, I think I should go into total care. But in 2015, when I was diagnosed with cancer and told me I wouldn't live for 6 months, I got all the papers together and I brought them up to her, and I literally went over all the different forms that Maryland had, advanced directives, and said, look at this, not only tell me, why don't you think about doing something like this for yourself? So she had something as a guideline to think about. And that did spur the next year for her to do the paperwork and share with me and say, is this what you need?
Good idea.
So we hit resistance at least 50% of the time.
Oh.
At least. So, you know, a lot of times it's just getting into the home and just, you know, letting them know that we're not there to threaten them. We're there to help them keep their independence. So, again, it's really more for the family. So,
I was gonna say, as far as rehab goes, what I see a lot in the hospital is the person that they said, I recommend rehab, and the person says, oh, I'm not going, I'm going home. And then they go home and it's not what they thought it was gonna be. They're not able to get on and off the toilet or in a bed, or the family's like, yeah, this isn't what we signed up for, this is a whole lot. You can get to rehab from home. So if for some reason you make a bad decision, or you make a decision that has gotten everybody in an uncomfortable situation, you can come to rehab from home. You can come to rehab from assisted living, you can come to rehab from home care, from palliative care, from caregivers. So we can get you from home. You know, just keep that in the back of your mind. If a neighbor you have that's at home and is struggling, just got out of the hospital or has been sick or something like that, if you decline it in the hospital, you can have the option to come from home. It's a little trickier, but we jump through hoops for you and make that work. So you always have options. Again, if you know your options, it's better than not. So just keep that in your back pocket. Heaven forbid you need that. You can get into rehab from home. My rehab, not all rehab. Yes, ma'am.
If you do that, if you go from home, do you have to be referred by a physician or
No,
someone?
you call me directly and I handle it for you.
Call you directly.
Yeah, so what we do is we have to triage from the hospitals first, because they're usually the more critical patients. But then we put you on our list and, you know, things change as our bodies change throughout the day. So sometimes who looks good to be discharged in the hospital in the morning, in the afternoon, sometimes things change. And then we go, oh, Mrs. Smith's at home, she's ready to go, let's get Mrs. Smith in. So yes, we do not need a direct referral. Yes, ma'am.
I've asked through the chat if anybody online has a question, but I thought maybe if you guys check in with them before.
Hey, you guys from online, does anybody have any questions from home? Hi, Miss Sarah. Hi, Chuck. Hi, Claudia. Hi, Aaron. Anybody have questions from home? Miss Sarah, we've been admiring your kitchen this morning.
Oh, I didn't realize I was on. Thank you. This
Any
is,
questions from us, Miss Sarah?
pardon me?
Any questions for any of us?
It's interesting to hear about the long-term care. I qualify, but my husband does not. And, we do have, we have the thing in the refrigerator. And he is dealing with pancreatic cancer right now, and it's at the metastatic stage. I'm lucky because he is very upfront about his wishes. And I was interested to hear what you had to say. We've gone through this with my mom, who was 100 before she passed away. And I know often these things are very last minute. And it's not a topic that you necessarily want to sit down and talk to with your family, but it certainly is important. And I know recently my husband went in for chemo with Dr. Smith in Easton, and they wanted to have his, preferences in terms of his living will. So they do have that. And I have to say, with University of Maryland Midshore Health, it's very helpful to have a localized place for all the information that you get from the various doctors. But it's also really nice to hear what you all have to say, because I think that you can't always choose what you'd like to have. And that's a tough thing. You know, I know when we were with my mother or my father-in-law in Washington, they would not tell us what would be the best rehab place for my father-in-law. And in a way, I was upset that they couldn't give more information referring to his personality and what he needed.
I think that's hard when you're in those situations, because a lot of times, yes, the hospital is not going to tell you. Maybe if you get a nurse in the hallway or ask one of the aides, they might tell you, but the doctors they're not allowed usually to say what their favorite place is, because that's like a kickback. That's why we are excited to have this information out there, so that you do have the information and can ask around. But I'll tell you, a nurse goes a long way, or an aide goes a long way, so if you can get some of those ancillary people, if you need a hot tip, they're the ones who know what's really going on the ground floor of a lot of things. Or if something happens and you aren't happy with your care, you can ask for, who's the person in the hospital? It's the resource.
I'm the person, an advocate.
An advocate, you can ask for an advocate in the hospital, and they can sometimes help you steer through things as well, or your case manager. Sometimes they can give you a little bit better information.
Oh, I have one other question. Do you all advocate for having a hospitalist? Or is that kind of what you all are doing in terms of being the person to sort of go between? Who do you turn to for that?
In the hospital, or you're just need
Yeah,
information?
maybe in the hospital, somebody who can coordinate things. I mean, is there such a person?
If you're in the hospital, you get a case manager. That's the person
Okay.
in your care.
All right. And if you're not in the hospital,
If you're not, then you can usually ask your doctor, or you can call around to any of us. I mean, I don't know how you guys feel, but you can always find one of our business cards, or it'll be online, I guess, from this presentation, who you spoke to. I
all
don't know
right.
to shoot you in a direction. Doesn't even have to be about, everybody's shaking their head. It doesn't even have to be about Pam. If you can find one of our phone numbers, we can either help you and get you in the right direction to ask someone else. It just gives you some information in general. Everybody's shaking their head. But if you find one of our cards, we're happy to help just kind of give you information, because it's hard. Healthcare is a lot. This whole conversation, this is a lot of information, you guys. So, like I said, when my mom comes to these things, she goes, I need like about a week to process it all and think about it all. So yeah, but if you have any questions, feel free to reach out to any of us, and we can at least try to get you some information. But if you're in the hospital, it's your case manager, or if that's not getting where you need to be, a patient advocate helps you too.
Thank you so much.
You're welcome, Miss Sarah. Good luck with your husband.
Thank you.
What happens, if you're in the hospital and you need to be discharged, they want to get rid of you, and you have, the type of insurance that has to have prior authorization, do they come through pretty fast on that, or are you?
Well, so if you have chosen an Advantage plan, think about it very different. Think about it some more.
Yes.
They are really great until they're not great. So when you need care, they're not great. If you don't need care, fantastic. A plus. So, depending on your insurance company, it can take anywhere from 24 hours to sometimes a week. And that hospital is going to be on you to get out. They want to know every minute of the hour where you are in your claims process. So the problem is that, like Jane said at the beginning, you're on the clock when you come in the hospital. They're nickel and diming you for every second that you're there. And they want to get you out. So what they're going to say is, because you're waiting for your insurance authorization, we're going to send you somewhere else while you wait. Or you don't have that option, we want to send you somewhere else because we don't want to have you waiting here. So you have to be the one that says, oh no, I know I can wait, or I know the care that I want, or if the insurance company denies me, I can make an appeal. So you have to sometimes be your own advocate. Because they do want to ship you out to the path of least resistance is what they're going for. So if somebody can take you today and your insurance company, they don't want to wait, they're going to say, you can go today. Oh no, I'm going to wait for my insurance company and see what they say.
Good to know.
I hope I'm not saying anything that makes them comfortable, but I just really want to be honest. This is what I would tell my family. For the Medicare Advantage plan, if it is not part of your retirement plan and you have opted in on your own, you do not have to wait until open enrollment to opt out. Let me say that louder. If you want to opt out in July from a Medicare Advantage plan, you can opt out in July. It's going to take you to the first of the next month, but you can opt out and go right back to Medicare the next month. Your broker is going to tell you you have to wait for open enrollment. You do not have to wait for open enrollment. That is not how it goes. So again, if you want to get out of your Medicare Advantage plan and go back to Medicare, you do it whenever you want. Now, if you're in the hospital, that's going to get tricky with the bills in between. We had a guy that had an Advantage plan. They recommended him go some places he didn't want to go. He opted to go home instead and start with home care and get a caregiver. Waited till the next month. He switched back to Medicare and we got him in the next month for rehab. And then we transitioned him back when he got done with us, back to home care and back to caregivers. So there are ways around things, you just have to know what to ask for. Yeah.
So what if you're like me and I retired from the state of New Jersey and I have a Medicare Advantage plan? I'm
So-
stuck with it, right?
Depending on your financial situation, sometimes people can opt out, but then you usually are responsible for the benefits on the other side, like you'll lose the whole package. Which man, they get you good on that, don't they? It stinks, I know, it's not
Covering
great.
my daughter till she's 26 and.
Yeah, so I would make sure that you tell your retirement people that that's not what you want, and maybe next time they'll pick a different plan. Probably not, because it's cheaper. But then I would say you have to be your own advocate, and you have to say, I know I can appeal, I know I can do this, I know I can do that. It doesn't always work, but if you can ask all the questions and fight for as much as you can, and that's what you need to do, unfortunately. But asking the questions is the first step. Yeah.
No one has, other than Ginny, has mentioned costs involved with, from heart fails to rehab, home care, and all of this. I'd like to see that issue addressed and
Okay,
how
yeah.
people can manage the situation that.
Sure. So I just wanted to back up real quick. Erin had mentioned, ask your doctor for resources. Most of the time, what I have found is that your doctors aren't interested in resources. That is for the nurses or whatnot. They are focused strictly on you and your medical care. So keep our numbers. Please reach out to us for anything, because we can refer you out to the right people. So, costs. So Home Instead, like I mentioned earlier, we are a private pay company, but again, we do take the long-term care insurance. Erin was just mentioning the fact that your gentleman went home with caregivers, and so we hire care professionals. They're our employees. Home Instead's been in business since 1994, and we've got it kind of down pat of who to hire and who to send into the homes. So our rates are anywhere between $37 and $42 an hour, depending on kind of what we do, where you're located, things like that. But with that comes payroll, taxes, quality assurance, background checks, drug testing, you name it. So we just write the check, we take care of everything else.
You mentioned the price, but is that, can someone be hired for an hour, or do they have to be hired for?
Good question. So we do have a minimum, and that is 8 hours a week. And it's 8 hours a week.
A week?
Yes, yeah, that's our minimum. So we generally like to do at least 2 4-hour shifts. And 1 hour isn't generally ever something that we do. It's very, very, almost impossible to find somebody who will drive 20 minutes to go work an hour. So,
But if you just need help with a shower.
yep, if you need help with the shower, you're going to need help generally with something else. So we can help with housekeeping, meal preparation, transportation, you
The same
name it.
person.
The
does
same
all of that.
person, yeah. So we will always have consistency in the home. We're gonna have Susie going to you every Tuesday and Thursday from 10 to 2, if that's what you chose, because it's your schedule. You can ask for what you want, what works best for you. And we have clients we've had for 12 years with the same person.
And they use their vehicle for transportation.
We can use your vehicle, and there's no additional mileage fee, or we can use our own vehicle, and it's 67 cents a mile.
Okay, so it doesn't have to be my vehicle.
No, it doesn't have to
your
be.
vehicle.
Right.
Because I have a van and everyone's not
Not one,
used
yeah,
to driving
right,
something
right.
like that.
So So Medicare will never pay for non-medical in-home care. At least not now. Who knows in the future? It might save the hospital a lot of money. I don't know, but, so does anybody have any questions about my costs, about our costs? Yes.
If a person, you said you take long-term care, but in order for you to take that, the person that you're taking care of has to need 2 of the 5 requirements.
Yes.
Otherwise, you pay out of your pocket.
Yes.
I don't need those care.
Right. Long-term care is only gonna pay for, and that's not up to us generally, it's the long-term care policy who says yes or no. Yeah, so, all right, so Megan, she's the other kind of private pay.
So ours is kind of tricky because we have we have the assisted living community, and there's 3 different types of apartments there. So each one has a different rate. We also do level of care. So the cost for somebody that comes in that can that's more independent is not going to be the same as somebody else. We also do medication management. So there's 2 different prices for that too. And then there's the memory community, where it's different pricing too. So our apartments start around $7,600 a month. That also includes all your meals, all your transportation, activities. We have housekeeping that's coming in your room every day. We have caregivers, so that includes everything. Besides the level of care. So if you need a lot of assistance, you might be a level 4. We're helping you eat and things like that. We have people that have a level 0. So if you moved in tomorrow, you wouldn't have a level of care and med management fee. But our apartments start at $7,600 a month. We are private pay, same as Jane with the long-term care insurance.
So just to give you an idea of what one-on-one care in the home would cost compared to assisted living, so it would be really expensive. So we're around at least $20,000 a month, just to give you some sort of an idea of what you can get in assisted living. Yes, like I said before, it's not one-on-one care, but you do have all of that comes with it. So I don't want anybody to kind of gawk at $7,000 a month because it's a good deal. I will say that, again, you have to do what's right for you and your family. I'm all for in-home care. I have been for 13 years, but my mom lives in assisted living because that's what works for us and our family situation. Because again, we waited until the crisis. Well, she waited until the crisis, but yes.
What did you mention? You said a figure, but I didn't catch it.
So in-home care for 24 hours a day, if you were to hire us one-on-one, it's over $20,000 a month.
That's
24-hour
care.
24-hour care, yeah.
And the other is based on what you need the person to do in those 4 hours twice a week.
Yes. Well, generally, again, we're right around 37 to 42. If you need kind of a lower level of care and you're right here in the Easton community, it's going to probably be around 37 an hour. But again,
and
an
8
hour.
hours was the minimum.
Yes, per week. I will say that there are a lot of times, of course, when somebody comes out of rehab and goes home, we can start with 24-hour care if that's what their recommendation is, just to kind of transition safely back home with new equipment, you name it. And then as they gain their strength with in-home physical therapy, we can decrease those hours. If you don't need any help overnight, getting to the bedside commode, then, we can get rid of the overnights and then maybe do split shifts every day. We've seen people go from 24-hour care to 8 hours a week. So, it just really depends. We're here to keep you safe and in your home. So, but again, if it's just too much and it's too much financially, assisted living might be the best option. So. We have 5 minutes left. Any other questions?
I only have one other comment. Claudia says, thank you for this excellent panel presentation and discussion.
Okay, thank you, Claudia. So again, fill up a bag over there with all of our information, and just feel free to reach out with any additional questions, because we all know that when you leave here, you're gonna think of a question or two, so.
Well, and I would ask, I also
Yes.
have your contact information, so if you each have a card or I can take a picture and send everybody an email and then.
Oh, that's a good
Yeah.
idea.
Okay.
I think that way they have everything all in one place.
Perfect.
Good.
Thank
That's
you.
great.
That's
Good.
Well, thank you, everybody.
Great question. Very good.
So